So very good evening, one and all. Very good evening, ladies and gentlemen. A very good evening, fellow doctors. Uh, we all have gathered for an academic feast that is to follow. As you all know from the latest ICMR INDIPE study, which was published in the Lancet a few months back, we are at the brink of not just being the world's largest capital of diabetes with more than 100 million patients, but also having 315 million hypertensives uh, as far as projected numbers right here in India. Challenges to the same may vary, be it in clinical practice or even depending on the geographical surrounding that you're around. To add further to insult to this, another thing which is becoming a scenario more at the Indian clinical practice is heart failure, which uh, is the need of the hour, so that we can get more empowered as physicians to approach these patients and ultimately treat them, be it HFrEF or HFMREF or even HFpEF. To throw more insight and give clinical pearls on the same, we have the teachers, the stalwarts, the gurus in cardiology with us today. And I have the honor of introducing both our esteemed gentlemen for the day. Next. Can we have next in the slide? Yeah. So for the first discussion, we have Dr. Michael Weber, who's a professor of medicine at Downstate College of Medicine of the State University of New York, who's done an extensive work in hypertension and preventive cardiology. He's authored more than 500 articles in peer-reviewed journals, and is also the founder of the ASH, the ASH Hypertension Specialist Accreditation Program, and multiple more programs too. He's a fellow of the American College of Physicians, the American College of Cardiology, and the American Heart Association. Next. We also have with us Dr. Jamshed Dalal, who's Director of Cardiac Science at Dhirubhai Ambani Hospital and Medical Research Center, Mumbai, who has over 40 years of experience after as a cardiologist. He's done extensive work on angiography and angioplasty, and is an editor of multiple journals and books with numerous publications in peer-reviewed journals, both national as well as international. He's the course director and speaker at multiple cardiac congresses all across the globe. So I first invite Professor Weber for his discussion on hypertension. Professor Weber, an honor to have you. Over to you, sir.
Well, thank you very much for that very nice introduction. And let me say what a pleasure it is to join so many colleagues to talk about some of the highlights of the meetings of the American College of Cardiology just earlier this month in Atlanta. But before I do that, I must say something before I forget it. And that is to remind people that in February 2025, a little less than a year from now, the World Hypertension Congress will be taking place in Chennai in India, a collaboration between the World Hypertension League and our colleagues in the Indian Society of Hypertension. It will attract leading hypertension experts from throughout the world, and of course from India. And I hope those of you who are available to attend will give it serious consideration. I think it's going to be a major highlight, and I think the first time that we or the International Society of Hypertension will be involved in a meeting of this magnitude and importance in hypertension within India. So exciting program, not that many months from now. Okay, let's get back to the American College of Cardiology. And let me start by sharing what could be considered as good news because it shows some improvement in what has been happening in hypertension during the past 30 years or so, but still in other ways very discouraging. We're looking at women and men aged between 30 and 80. And if we look left at the women, we see some improvement. If we look at the proportion whose hypertension is now controlled, it has increased during that 30-year period, but it is still very, very low. Even more people who are being treated are still uncontrolled. Many people are simply untreated. And worst of all, over half of all women, maybe now just about half of all women, don't even know that they have hypertension. And if we look at men, it's even worse. And we can see that so many men still do not know that they have hypertension. And the proportion of men with hypertension who actually have their blood pressure under control, less than 140/90, is very small. And here's a bit more detail, just looking at control rates, who is less than 140/90, according to where they are in the world. And you can see overall, barely 20% of people around the world with hypertension have their blood pressure controlled. Yes, we do a bit better, a bit over 40% in high-income Western countries such as Europe, North America, Australia, Canada, places like that, and also do reasonably well in high-income Asian Pacific countries like Japan, Korea, Singapore, and what have you. Not too bad in Latin America, but it gets worse and worse. And so as we get into Asia and South Asia, we see that control rates are less than 20%. Very discouraging, and it tells us we have a huge amount of work to do. Here we're looking at women, and if I switch to men, the same story, but even worse. Even in the best of countries, we still do not achieve blood pressure control. And that includes the United States with all of our resources. And what's even worse, in the United States, things were improving very nicely up to about 2015, 2016. And then they started to deteriorate. They got worse. We can't blame COVID. We can't blame the pandemic for this, because this happened before COVID came along. And it's still continuing. And it's a reflection of the fact that doctors don't have enough time to deal with hypertension. We're not getting enough support from industry in some ways to educate doctors about the importance of dealing with hypertension. Altogether, it's so discouraging to see after all those years of progress that things are now starting to get worse instead of better. And if we look at hypertension-related cardiovascular mortality, and just look at the right side, urban people. This is in the United States, and most people do live in cities or what we call urban centers. It doesn't matter where in the United States you are, mortality related to hypertension has increased over the last several years and keeps on going up and up. Again, a reflection of the fact that doctors are being distracted, perhaps dealing with too many things, perhaps not having enough time for each of their patients, and poorer blood pressure control, increasing cardiovascular mortality. So what can we do about it? Well, we can do some obvious things. We can, first of all, get the patients involved and get them, if we can get them to measure their blood pressure at home, that improves their adherence to treatment. That alone would improve blood pressure control, because so many people, even after they get a prescription or get their pills, do not take them. We also can talk about new drugs that have been developed, and I'll come back to that in a couple of minutes. And I'll also briefly mention renal denervation. And the reason I'll mention renal denervation and new drugs is because that was a big part of what was discussed and presented at the meetings of the American College of Cardiology just a couple of weeks ago. And I wanted you to share in the latest information. So what can we do to improve blood pressure control? It's what I call better housekeeping. Before we get to new drugs and renal denervation, which are important and exciting developments, let's see what we can do better with what we already have. There was a recent study published, and I show the title of the study because it includes some very distinguished scientists, people renowned for their leadership in public health. And you can see more than 2 or 3 of them are actually people in India or of Indian origin, but also people like Daniel Lackland and Donald Lloyd-Jones, who in the United States are very major public health authorities. And everyone knows the importance of salt. And this is just one study that they conducted, and it simply shows that if you put people on a low salt diet, people who are taking a usual diet, which is high in salt, typically somewhere around 6, 7, 8 grams a day, in some countries more than that, and I suspect in India more than that, and bring them down to where they're supposed to be, which is 5 grams of salt a day or about 2.4 grams of sodium a day, within a week or two, the blood pressure falls very significantly. So it's not like it's a long-term prospect, nothing happens, and you have to sort of keep on struggling and hoping for something to get better. You see a good result within just days of going on a low-salt diet. And you can get used to it, and it's not that difficult to follow. After I say that, I know nobody does it. And it's so hard, in a way, to eat a low-salt diet because so many of the foods we buy or get in restaurants or fast food places or even buy in our stores and our grocery shops come with so much salt already added. That's a problem we have to deal with, and our politicians and public health authorities have to deal with. One of the most upsetting things, though, is that adherence to medicines is so poor. And basically, many patients don't take their medicines at all, and many of them take some, but not all of their medications. So it's not a big surprise that so many people, even when they're being treated for hypertension, do not have their blood pressure controlled. And we as doctors write an extra prescription with an extra drug thinking that's going to help, without realizing that maybe the patient is going to take the new drug we've just prescribed and forget about taking the old drugs. And to explain all of this to patients takes time, and often we don't have time. It's a real problem. This is one other solution beyond talking to patients about the importance of taking their medicines. This is from Roland Schmieder in Germany, showing that if you give patients who are on more than one medicine, their medicines, 2 or 3 medicines in one pill, rather than writing or giving them 3 different prescriptions, 2 or 3 different prescriptions, if you just take the medicine in one pill, the persistence or the compliance with treatment is so much better. I love it when I can say to a patient, I can control your blood pressure with 1 pill a day. Now that 1 pill may have not just 1, but 2 or even 3 medicines in it, but that is the way to go. And not only do you get better adherence, but you get lower mortality if you can use single pill therapy. And that is why, if we look at the guidelines of the European Society of Hypertension, the European Society of Cardiology, if you look to the left of the slide, when they show how you start treating hypertension with ACEs or ARBs, and then use a CCB or a diuretic, they like us to start with 2 drugs at once. Let's get this blood pressure under control as quickly as possible is the theory here. and then maybe we'll add whatever else we need to add, a diuretic typically. But they say try and do it all with a single pill. The American guidelines likewise. And the reason I'm stressing this is because in India, you have a better selection of single pill therapies with 2 drugs, 3 drugs, all sorts of combinations, all sorts of doses. You have a far better selection of drugs to choose from than we do here in the United States. And for you, it should not be difficult to control hypertension, and I would say 80% of your patients with just 1 pill a day. And that pill would usually have an ACE or an ARB in it, plus a calcium channel blocker or a diuretic, whatever you like. And you've got choices of different calcium blockers, choices of different diuretics, choices of all the different ACEs and ARBs, so many possibilities, all in a single pill. Another thing we can do to make people more adherent to their treatment and to exploit what we've given them, because it's such a tragedy when bottles of pills are sitting in someone's medicine cabinet or in a cupboard somewhere and not being taken. What a tragedy. If we get people to measure their blood pressures at home, and that's happening more and more, and say to the patients, you be in charge of your blood pressure for the time being. I want you to be on top of it. Once patients start seeing higher blood pressures and know the consequence of high blood pressure is that they are going to be at risk of a stroke or heart failure, they're going to get far more serious. And this is a study from South Korea, but an important one published 2 or 3 years ago, going from left to right. Once you got people to measure their blood pressure at home, far more people were adherent to the treatment, and the number of people who were skipping their doses or not taking everything they were prescribed reduced. Things got significantly better as soon as people started measuring their own blood pressures. Okay, now American College of Cardiology, a couple of weeks ago, Atlanta, a lot of focus on hypertension. I was so pleased about that, that hypertension really was getting a lot of attention. And there are 2 or 3 new classes of drugs that were presented and discussed in detail and caused a great deal of interest. Now, let me say immediately that most of our patients, 80% of them, probably can be controlled well with what I've already talked about, drug classes we already have, and in all the correct combinations of those classes. We already have terrific tools, but sometimes we need new and better tools. And that's what the cardiologists in Atlanta were very excited about. And I'll go through some of these new developments. First of all, everyone knows that aldosterone is important. It's not just an occasional cause of secondary hypertension. It's probably a cause of poor response to treatment. In a large proportion of those patients, we find it hard to bring under control. And they often, that's because of high aldosterone levels. Well, we've had a drug for treating high aldosterone levels for a long time. It's called spironolactone. And it does work, but it's got side effects. And patients don't like it and they don't take it. And you can prescribe spironolactone, but a year later, only about 10 or 15% of patients are still taking it. Well, that's no good. That's frankly futile. But now there are 2 new types of drugs that do the same thing and are very, very well tolerated. First of all, drugs which, like spironolactone, block the mineralocorticoid receptors and help to eliminate salt and antagonize the effects of aldosterone, so-called non-steroidal mineralocorticoid blockers, and I'll show you an example of one of those. And the other is inhibitors of aldosterone synthase. In other words, we just reduce the production of aldosterone from the adrenal gland with a drug that also is very well tolerated. This is a study published in Hypertension 2 or 3 years ago with a non-steroidal drug, isoxazolinone, compared with eplerenone, which is an older mineralocorticoid drug similar to spironolactone. And this new drug, very well tolerated, was in fact significantly better than eplerenone in reducing blood pressure. Very exciting. Even in a low dose, it was very effective. In a high dose, quite remarkably effective. So I think that is an important way forward. So now, for your fourth line drug, if you need something that's different and you think that blocking aldosterone is a good thing to do, which it probably is in a large proportion of patients, here's a drug that does at least as well as spironolactone in terms of reducing blood pressure and doesn't have side effects. And here, another drug, baxdrostat. This is a drug that stops aldosterone from being produced in the adrenal gland. It doesn't completely stop it. We need some aldosterone, for goodness sake, but it significantly reduces it. And here we see dose-dependent effect. The more baxdrostat we give as a dose, the better we reduce the amount of aldosterone, and the more we reduce blood pressure. So here are two nice ways of dealing with difficult to treat hypertensive patients. Here was something that also got a lot of attention at the meetings of the American College of Cardiology. A new drug just approved, by the way, by the Food and Drug Administration in the United States, a drug that blocks endothelin. Now, we've never had an endothelin blocker before for treating hypertension. Yes, we've had some endothelin blockers available for treating pulmonary hypertension, which is a totally different disease. Now, there is a drug, an endothelin blocker that works for general hypertension. And bear in mind, endothelin is a strong vasoconstrictor. And so by blocking endothelin, we can get very nice blood pressure reductions. And this is the definitive trial that led to the FDA approving this drug. And if you look at the right side of this graph, it's a complicated graph, and I don't want to waste time going into all the details. It was an unusual study design where everybody was treated with this new drug, aprocitentan. And then after several months, in a randomized way, half the patients remained, and that's on the red line, remained on the drug, and half of them were randomized back to placebo. And you can see a big difference, several millimeters of mercury by ambulatory blood pressure monitoring, a really powerful effect being demonstrated of this blocker, equivalent to roughly 10 millimeters of mercury in office blood pressure. So that's good news, and that's a drug that will be helpful as well. But the biggest attention, well, I shouldn't say the biggest attention, but a lot of attention was with a drug that's not yet approved and not yet available, but it's a drug that you give by injection. That sounds a little inconvenient, doesn't it? But it's a simple subcutaneous injection, which a nurse can do. It doesn't require any sort of sophisticated maneuvers, just a simple subcutaneous injection. And it's with a drug that works for 6 months at a time. Can you believe that? It is called zilebesiran, and it's a brand new kind of pharmacology. It actually goes to the liver. It's a small interfering RNA, and it interferes with messenger RNA, and it prevents the production in the liver of angiotensinogen, which is the precursor, is the main substrate for the renin-angiotensin system. So right at its very origins, this drug, in a sense, wipes out the renin-angiotensin system perhaps more thoroughly than any of the blockers of the renin-angiotensin system, like the ACEs and the ARBs, that we already have. And this shows, when we look at angiotensinogen levels over a period of several months, they are all significantly reduced down to less than 80%, and ultimately down to less than 90%, with the sorts of doses that we expect will be used in clinical practice. We get rid of 90% of angiotensinogen just with an injection given every 6 months. These are the three big studies that have been planned. Actually, Cardio 1 and Cardio 2 being completed, and Cardio 2 was presented as a major trial at the meetings of the American College of Cardiology. Cardio 3 is a study yet to come. This is what they found in Cardio 1, really a big 14 millimeter of mercury decrease in systolic blood pressure 6 months after the injection. To me, that is absolutely astonishing. And here, again, presented in Atlanta, on top of other drugs, we see these very big differences, almost 19 millimeters of mercury when you give zilebesiran. This is after 3 months, and it was equally as good after 6 months. We see the zilebesiran beats the placebo by 19 millimeters of mercury on top of amlodipine. Again, a very strong effect. And interestingly, even when given on top of olmesartan, which is an angiotensin receptor blocker, in other words, the patient's already getting a blocker of the renin-angiotensin system, we still get an additional 7 millimeters of mercury reduction in office blood pressure. What's that all about? Well, it's telling us that the renin-angiotensin system is complicated. And it's not just one simple system. Many individual organs, adrenal glands, even the wall of the heart, all sorts of tissues have their own little independent renin-angiotensin systems. And sometimes it's an ARB, sometimes it's an ACE inhibitor. And for the most part, too, it's a drug like zilebesiran, the new one, that can block the system in different ways. We need to learn more about that, but still very exciting information. And as you can imagine, a lot of people are very excited about this drug, because one small injection a nurse can do every 6 months, and you got these sorts of reductions in blood pressure. That is fun. Okay, renal denervation, the last thing I need to talk about. It reduces blood pressure on average by 10 millimeters of mercury, and therefore, all by itself would reduce stroke and kidney outcomes by about 20%. And what's great about renal denervation is that it reduces blood pressure, I'm not going to say permanently, but we know at least for several years. And that is independent of whether or not patients is taking pills and whether or not the doctors are prescribing pills adequately. In other words, it's what they call one and done. You do the renal denervation and you get a relatively permanent, very nice, useful reduction in blood pressure. May not be enough to completely control the blood pressure, but a huge improvement for each patient who needs it. Why does it work? Well, first of all, how do we do it? We put a catheter into the renal arteries and put energy across the renal arteries, radio frequency or ultrasound, that destroys the renal nerves, because the renal nerves run parallel to the renal artery. And so by this method, we can destroy the renal nerves, and that has two effects. First of all, it decreases sympathetic supply to the kidney, which blocks the renin-angiotensin system, which increases diuresis, natriuresis, and causes vasodilation, which further helps to reduce blood pressure. But it also reduces the signals from the kidney to the brain and causes the brain to reduce central sympathetic outflow. And so it reduces total body, total systemic sympathetic activity. So this one procedure has several ways of working to reduce blood pressure. This is a summary of several studies done with ultrasound renal denervation. I'm not going to waste everyone's time going through this one by one, but on average, we're seeing very nice reductions in blood pressure measured after 3, 6, 12, and 24 and 36 months, and very well sustained. Once it works, it works. Here is a more detailed look at patients who had radiofrequency ablation. And again, we're seeing nice falls of about 10 millimeters of mercury in patients of all sorts, people with previously resistant hypertension, people with diabetes, older patients, people with atrial fibrillation. By the way, atrial fibrillation may itself be improved by renal denervation. Another story for another day. Chronic kidney disease patients respond well. People with isolated systolic hypertension respond well. People with histories of strokes and myocardial infarction all do well following renal denervation. And here's a small study which showed that hypertensive emergencies become significantly less common in people who've had renal denervation. So every way you want to look at it, renal denervation is exciting. Now it's more complicated. We have to put a catheter into the renal artery. It takes time. It's a procedure. It's obviously somewhat expensive, but it's already being done in India. It's approved in India, and it's going to be a useful alternative for people who are just not doing well with medications. And in fact, at the American College of Cardiology, a third way of causing renal denervation, I wanted to show it to you because it was presented as a late-breaking clinical trial to an audience of thousands of cardiologists, everyone very excited, presented by Dr. David Kanzari. And it's the same thing I've just been talking about, but now instead of ultrasound energy across the wall of the renal artery to destroy the nerves or radio frequency energy, now this is a new catheter that actually injects small amounts of ethanol across the wall of the artery and destroys the nerves. It's an old technique used for reasons other than the ones we're talking about, very safe. And it also, guess what? Reduced blood pressure on average by about 10 millimeters of mercury, whether you measured it by ambulatory systolic blood pressure or by office blood pressure. So all good, all exciting. So in summary, what happened at the American College of Cardiology? What am I trying to say? Here is all in one slide. We focused on limited progress in the treatment of hypertension and a lot of concern that control rates for hypertension are falling in most countries. Poor adherence to treatment remains a fundamental problem. And strategies that can improve adherence, I've mentioned them, of course. Routine use of combination single pill therapies, a big opportunity in India. Patient self-measurement of blood pressure, again, a big opportunity in India. And interesting and well-tolerated new drug classes that are going to expand treatment options for people who are patients who are genuinely difficult to control. And there was a lot of interest on device-based renal denervation. It's not yet available in the States. 2 of the procedures have been approved by the FDA, and they will be available. They already are technically available, but we're going to see these techniques introduced steadily over the next few months, over the next couple of years. So very exciting meeting, a lot of focus on hypertension. Let me stop there and allow Dr. Dalal to take over. So I'm going to stop sharing my slides. If I can, I might need some help because I don't see the button to go. Oh, thank you. Thank you for rescuing me.
Thank you very much, Professor Weber. I was quite interested about hearing the 6-monthly injections of hypertension control. And as you know, we have inclisiran, which is a 6-monthly for lipid control. So imagine putting all the patients on just 2 injections every 6 months, and what a dramatic reduction it would produce in cardiovascular disease by controlling their hypertension and lipids. So it's certainly a future therapy which sounds extremely exciting, and I think that's a great way forward for treatment of these problems. So I'm going to talk about the ACC Guidelines 2024, predominantly related to heart failure with reduced ejection fraction. And one thing I would like to point out is, of course, there have been no major new trials or any studies to further augment the guidelines that already exist. So basically, what ACC has done is highlight some of the important features of what we already have and how we can use these to improve the management of heart failure with reduced ejection fractions. So they started off by saying that there are 10 issues. in issues related to implementation of the guideline therapy, which I think is most important, because still, in spite of having all these guidelines, many patients are still not initiated. And of course, many of them never reach the target prediction of reduction of managing the total target dosages. Then they, of course, talk about addressing the challenges, which is when to refer them to heart failure specialists, the problems of adherence, which are similar to the treatment of hypertension, and of course, medication costs and the availability and access of these medicines, and of course, management of these patients who are often old, fragile, with complex comorbidities. So really, there are multiple issues that need to be looked at in these patients. As far as initiating of GMT is concerned, I think it's important that approach for each patient should be individual. After all, heart failure etiologies are different, patient ages are different, comorbidities are different, and therefore you need to approach each patient as an individual rather than as a group of just heart failure for rapid treatment of all patients. The other important part about the initiation of guideline-mediated therapy is that it should be early and as rapid as possible. So I think both factors are important, early and as rapid as possible. So especially patients who have not been on heart failure treatment, it's important to reach the target or the maximal tolerated dose of all the 4 key medication classes as soon as possible, preferably within the first 3 months. And of course, there are complex problems in individuals which might take a longer time. For example, those with CKD or other issues. But I think as far as possible, you should try and achieve within the first 3 months. And therefore, also it's important to remember that you could start all 4 groups in smaller doses. So I think there's an approach change that we don't need to use one drug, optimize the dose, and then move on to the second drug. But we should start early, try and achieve all 4 drugs, even if in smaller doses, as soon as possible, preferably within 3 months. Obviously, we need to look at the patient's phenotype. Patients have diabetes, hypertension, various other obesity, age, everything needs to be looked at. We also know that ARNI, for example, is better tolerated when the patient is still congested. That means wet heart failure. Beta blockers are better tolerated when the patient is less congested, dry heart failure. And again, beta blockers should be used only as per evidence. So you would not start beta blockers for the first time in a patient who comes with heart failure and decompensation. But if the patient's already on beta blockers and comes back with decompensation, then you don't stop the beta blockers, but you continue them. Important also to remember that often patients with heart failure have low blood pressure, and therefore drugs like mineralocorticoid antagonists, SGLT2 inhibitors, and vericiguat have very minimal, if at all, effects on blood pressure. And that's very important to remember because we know that ARNI is an issue when blood pressure is low. Again, when they talk about management, I think it's important, and this I think is particularly important of India. I don't know about other countries, but in India, we often start with very small doses, and then the patients are just left on those small doses. So I think it's important that we change the dose as the patient comes to us for follow-up. So you need to start with, say, bisoprolol 1.25 milligrams once a day, maybe very small dose, but again, try and reach the target dose of 10 milligrams. Similarly, with carvedilol, at least 25 milligrams twice a day, metoprolol 200 milligrams, and sacubitril valsartan up to 200 milligrams twice a day. So yes, no problem. Start with a small dose. Start all the 4 drugs with a small dose, but try and reach the maximum target heart rate because we know that that's important. Similarly, with eplerenone and spironolactone, we need to use up to 50 milligrams with eplerenone and 50 milligrams with spironolactone. Of course, fortunately, dapagliflozin and empagliflozin is the straightforward 10 milligram dose. Again, when we talk of vericiguat, that's another problem because we're supposed to start with 2.5 and then double it every 2 weeks. And I see mostly in India that doesn't happen. Patient remains for months on 2.5 milligrams with never reaching a dose of 10 milligrams. So I think not just starting the drugs, but I think optimizing the dose is something that the ACC concentrated on. So here's a treatment algorithm. This is not a new treatment algorithm. We've seen it before. You put the patient on all 4 drugs. Then, of course, you individually look at the patient. If the patient's got persistent volume overload, then more diuretics. If the patient is an African American or not responsive or not being tolerated with ARNI, etc., then hydrolysine isosorbide combination, which we have in our country, it would be a very good drug. If the patients on the other hand are still tachycardia in spite of multiple doses of in spite of optimal doses of beta blockers, then ivabradine comes into it, and you should try and keep the heart rate of all these patients below 70. And of course, if the patient has worsening of heart failure, which means the patient requires an increased dose of diuretics. The patient comes to the outpatient, and as doses increase, the patient goes to the emergency as an intravenous shot of diuretics. All that is considered as worsening. It doesn't mean the patient necessarily needs to be hospitalized, but these conditions require the addition of vericiguat. There's also a thought whether vericiguat can be the fifth pillar, and I think we can discuss whether all 5 pillars should be used or we should restrict ourselves to 4 pillars. Again, if we look at the 4 main pillars, ARNI, so clearly we need to shift patients who are on AC inhibitors or ARBs to ARNI. I think that's important and sometimes not done. We should do that. If patients cannot tolerate or cannot afford ARNI, for example, of course, AC inhibitors would continue. Again, the importance of mineralocorticoid antagonists and the use of SGLT2 inhibitors, especially in patients whose GFR is more than 25. So clearly for DAPA and SOTA, the GFR is more than 25. You need to watch them closely. Empagliflozin has been used for even lower eGFRs, and one needs to consider its use as well. Again, the evidence for beta blockers is very high, and beta blockers should be important use in all these patients. As far as diuretics are concerned, it's important that diuretic dose and the diuretic type depends on your renal function, whether you need loop diuretics or not. But again, important aspect is to not over-diurese the patient, not produce hypovolemia, and rather use the other 4 drugs to treat the patient's heart failure. So when blood pressure falls, the first thing you should need to look at is, are you over-diuresing the patient? And can you reduce or in fact even stop the diuretic and optimize the dose of maybe the mineralocorticoid antagonist or any of the other drugs in place of diuretics so that the blood pressure doesn't fall. Those who cannot tolerate or cannot use ARNI SGLT2 because of various issues that you do find along with comorbidities, kidney problems, hyperkalemia, fall in blood pressure, then of course hydrazine isodabite combination, particularly in heart failure with CKD, is important. And then of course I mentioned about ivabradine and vericiguat. We often don't use ivabradine often enough, but I think patients with tachycardia, in spite of beta blockers, or in those beta blockers, those who cannot be optimized and still remain more than 70 heartbeats, ivabradine is a very important drug to use. Ivabradine has been clearly indicated for heart failure with reduced ejection fraction, but not for heart failure with preserved ejection fraction. Vericiguat is the more recent of the drugs. It has a different mode of action, and clearly it's an important drug to use when patients present with worsening of heart failure. So I think nothing new has been said in the 24 guidelines. We talk of ARNI, ivabradine, SGLT2 inhibitor, and vericiguat. And clearly, we talk more about the worsening heart failure symptoms, which is something we should keep in mind. And of course, maximizing, important, of course, to remember that SGLT2 inhibitors can be used in those with and without diabetes. Again, when we talk of adjustments of dosages, if patients are already on high dose of AC inhibitors, you can straight away start with 100 milligrams twice a day of ARNI and build it up to 200 milligrams rapidly. However, if patients have not been on any AC inhibitors in the past, it may be preferable to start with 50 milligrams twice a day and then increase the dose. Also, patients who have got kidney impairment, hepatic impairment, or in elderly patients above 75, it may be wiser to use a smaller dose of ARNI and then gradually build it up. And then, of course, what are the triggers? Because I think the advent of the heart failure clinics is very important. I feel the advent and starting of a heart failure clinic, at least in India, has dramatically improved the management of heart failure treatment. In a hospital, once we started the heart failure clinic and we heart failure protocols and checklists, I immediately realized how important these checklists are and heart failure clinics are to improve patients' therapy. The checklist helps us to adjust the dosage, make sure we haven't missed out anything, improves things like vaccination, for example, which was often forgotten because now it comes in the checklist and it's an important part. Cardiac rehabilitation, which is an important part. So all these things being on the checklist in the special heart failure clinic is important. So I think physicians and cardiologists who are running general management of heart failure. Of course, majority of patients are managed by physicians and non-heart failure specialists. But I think in certain situations, for example, when there is a need for inotropic drugs, when there is heart failure symptoms persist, class 3 or class 4, heart failure with low blood pressure, heart failure with rising creatinine, patients with AF and ventricular fibrillation, patient getting hospitalized a couple of times in the year, inability to tolerate drugs, worsening biomarkers, for example, all these patients need to be carefully monitored and referred to a heart failure clinic. Again, it's important in the heart failure clinic or by any physician to monitor these patients specifically. For example, those patients whose heart function remains below 35% in spite of good medical therapy. Are these candidates who require device therapies? Do they require an ICD, CRT? So I think that's important. Again, you need to consider heart transplantation in these patients who get worse or do not improve in spite of guideline-mediated therapy. It's also very important to look at the cause. For example, if there's ischemia with a low ventricular function, and that's a very important topic, is vascularization worth it? Is it harmful or beneficial in ischemic cardiomyopathies? That's a whole topic by itself. Again, some patients may miss valvular heart disease. For example, you may have aortic stenosis, low gradient heart failure because of poor ejection fraction. Are we missing a severe aortic stenosis, for example? Does the patient have associated myocarditis? Does the patient have specific cardiomyopathies like transthyretin or sarcoid, which require specific treatment? I think these are important aspects that we need to look at when we are talking of patients with heart failure. So starting 4 drugs is good, but look at the etiology, try and correct the etiological factors, look for specific etiological factors when you're treating these patients. Now, of course, when you start these drugs, there are contraindications and cautions, and ACC has brought out these problems. For example, with sacubitril, valsartan, ARNI, you need to not start them immediately when the patient's on ACE inhibitors because of increased evidence of angioedema. So you need a gap. With the ARBs, patients don't need that gap. So it's important to remember that. Of course, most of these drugs cannot be used for pregnancy, lactation, and again, ACE inhibitors are problematic in patients with severe hepatic dysfunction. Caution, of course, when renal dysfunction is there, GFR 30 to 90, no starting dose adjustment required, but in patients with less GFR, you need to start with a smaller dose and watch them continuously. Again, patients with heart failure, with hepatic failure, we need to reduce the dose. Also, patients who got renal artery stenosis, be careful. Patients whose blood pressure are below 100 and those who are volume depleted. When we look at the SGLT2 inhibitors and look at the contraindication, the contraindicated in type 1 diabetes because it increases the chances of diabetic ketoacidosis. And again, patients, as you know, with very low GFRs, mycotic infections, volume depleted, patients who are due for surgery need to discontinue the SGLT2 inhibitors, patients who develop urosepsis, pyelonephritis, or acute renal dysfunction, one needs to stop SGLT2. If we look at ivabradine and vericiguat, again, ivabradine not indicated for heart failure with preserved ejection fraction. Those with severe hepatic impairment, if there's an acute decompensation, you may want to stop the ivabradine. Sick sinus syndrome and other forms of heart blocks, of course. Even patients with atrial fibrillation, it is advisable. And of course, ivabradine, as you know, doesn't work in this situation. Caution in patients who got prolonged QT intervals is important. With vericiguat, again, pregnancy is a problem. Again, concomitant use of PDE inhibitors, sildenafil, etc., is contraindicated. Please remember that. People do use nitrates and vericiguat, but sildenafil is contraindicated with vericiguat. Again, when you talk of specific patient cohorts, what ACC brought out was the South African population, the African population, where you may want to use hydroglyzine and isosorbide nitrate. But I think I should concentrate more on the older patients, the ones over 75, which are very common with heart failure. We definitely need to start a lower dose of guideline-medicated therapy. We have to look at potential falls. They often get worsening of kidney function. And don't forget financial toxicity because of these expensive drugs which have to be used, all of them at the same time. And you should also remember that efficacy of lower dose guideline medication treatments is in doubt. Do lower dose help? Do they not help? My impression is that any dose will help the patient, but the optimal dose will be a better effect on the patients. And of course, there's a whole group of these patients with heart failure, with frailty, elderly, frail individual, and how much is the impact of the natural history and how much is the impact of pre-existing diseases and the medical therapy. Then they spoke about the pathophysiology targets, and I think we all know what targets act, what drugs act on what targets. But I think what it shows is that the use of multiple drugs, we are targeting various things. So we know that we are acting and targeting the angiotensin, renin, aldosterone system. We are targeting the sympathetic system. Now we are talking about, say, acting on the nitrotic system, the sodium glucose transport system, and various others, the elevated heart rate, the ventricular arrhythmias. So clearly, we are now targeting all the factors, and all the pathophysiological targets have been targeted by different drugs, which is why the importance of using all these drugs, even if small doses, so that we can target all these various factors rather than restrict ourselves to just one particular drug. Now, again, principles of heart care. So the important highlighted the same factors. Target doses are associated with best outcomes. So whenever we treat heart failure patients, we should always keep this in mind, that target doses are associated with best outcomes. Important to rapidly achieve these target doses of all the recommended therapies unless there is a contraindication or there is an intolerance. Titration should occur even if the patient appears stable or the symptoms and the ejection fraction improves. So I think that's a very important point. As we always say, there is nothing as like a stable heart failure patient. So even if the patient comes to us in the clinic and the patient says, I'm fine, I have no problems, but he's on small doses of various drugs, please try and achieve target heart dose. Because as you see from the very first line, target doses are associated with best outcomes. Again, very important, even if the patient's ejection fraction improves, it is not necessary to cut down, stop, or reduce the dosages. We all know from several trials that if you stop these drugs in patients whose ejection fractions have returned to normal, then many times you may find that the ejection fraction drops. Of course, we need to again look at the individual patient. Is the rise in ejection fraction because the patient had an acute myocarditis, or the patient had an acute drug toxicity, or is it an ischemic cardiomyopathy or some other reason? So I think, again, individualization of the need for reducing or stopping the medicine needs to be taken into account. But clearly, titration should continue even if the patient is stable and symptom-free, and titration should continue and medicine should continue even if the ejection fraction improves. Failure to tolerate titration, that means that the patient cannot achieve more than very minimal doses of medicine, that is a need for referral to an advanced center, because we know that target doses are associated with best outcomes. Again, the importance of starting target medicines immediately and targeting and titrating at each individual dosages. So association with never titrating initial dose. So if you don't start GMT, specifically, I think that GMT should be started in the hospital, because patients who are not started on drugs in the hospital are often not likely to get drugs in the OPD and will not get adequate dosage of drugs and would be initiated too late. Try and finish initiation and titration, not just initiation and titration to the target heart dose within the next 2 to 3 months. And again, you must remember, simultaneous start of multiple agents is possible, and we try to do that in all our patients. The other principles of heart failure care they mentioned was you look at the tolerability and side effects, and that is very important. I think it's not so easy as one thinks to treat these sick heart failure patients with multiple comorbidities. Many of them have got ischemic heart disease. Many of them have got uncontrolled diabetes, renal dysfunction. Many of them are hypotensive. So clearly, these are very big, important issues. Worsening kidney function and hyperkalemia is really a big problem that we see. The survival benefit can happen even with low doses. So therefore, you may continue to low doses which do not affect the kidney function or hyperkalemia. And discontinue, for example, mineralocorticoids rather than ARNI in patients with potassium is a problem. But if you can give a very small dose of mineralocorticoids, it still might be worthwhile. You must also remember that SGLT2 inhibitors are beneficial, especially in patients whose potassium is rising the rise of potassium is less when the SGLT2 inhibitors are added to ARNI. So use these drugs to benefit one from the other. Again, patients who have systematic hypotension, another big problem while treating hypertension, and usually that is because of overdiuresis. Often patients are continued on some other blood pressure medicines or some other blockers, alpha blockers, for example. Some of them are amlodipine, which continues. So stop all other drugs which produce hypotension and reduce the diuretics as much as possible. Of course, the patient might have autonomic dysfunction, which also needs to be looked into. Again, clinical comorbidities and clinical judgment is most important. And therefore, if you have persistent hypertension or persistent hyperkalemia, then you need to refer them to advanced heart failure specialists. Now, again, if the patient has hypokalemia, please don't treat with oral potassium. It's better to increase the dose of mineralocorticoid antagonist, depending, of course, on the kidney function for these patients. So clearly, some of the very basic principles of heart failure therapy are emphasized by the ACC 24 guidelines. Now, one may think that this is so obvious that why should we need to think about it? But clearly, if you actually look at the patients, if we just took out a group of patients with heart failure and look at them in your clinical practice, we'll find that many of these patients have not been started early enough, are not on optimal doses of all the drugs. All these factors of balancing the various drugs are not usually done as much as we think that they are being done. Again, we have to look at both cardiovascular and non-cardiovascular morbidities. For example, coronary artery disease patients will benefit from revascularization. Now, which of these patients will benefit and who won't? That's another story by itself. Patients with atrial fibrillation, don't forget to anticoagulate them. Sometimes ablation or AV node ablation with CRT can produce dramatic benefits in terms of their heart failure. Patients who have mitral regurgitation, you can think of transcatheter mitral valve clips, which can reduce the MR, significantly improve their heart failure. As I mentioned earlier, aortic stenosis with low gradient may be missed and may be an important part of therapy for heart failure patients. And again, we have patients who got associated hypertension, dyslipidemia, peripheral vascular disease, and cerebrovascular disease. These, of course, are all very common associations with heart failure, and they each require their own therapy. Of course, when your patient have hypertension and heart failure, it's very easy. You optimize and maximize your dosage, which will benefit both the hypertension and the blood pressure both. Don't forget to treat the dyslipidemia, and of course, patients who have stroke and other issues along with heart failure, which make it even more complicated. And then, of course, you have the non-cardiovascular issues like diabetes, which is a big problem. Of course, SGLT2 inhibitors help in the management of hyperglycemia, but you need additional drugs. Don't forget the use of looking for sleep apnea as an important factor. Management of sleep apnea can dramatically improve symptoms of patients with heart failure. And again, a problem which has been discussed several times, iron deficiency with or without anemia. Please remember that low hemoglobin is not essential. You can have iron deficiency with a normal hemoglobin, and the importance of use of intravenous iron should not be forgotten. So do not forget other things like management of weight reduction, the management of proper nutrition, intravenous iron, vaccinations, and of course, cardiac rehabilitation also as a part of management. Malnutrition often becomes a problem with patients with heart failure. So managing nutrition is important. Poor nutrition worsens heart failure patients. So clearly, nutrition needs to be looked at. Many of these patients are anemic because of malnutrition and other causes. That needs to be corrected. If the patient has hyperkalemia, we now have new drugs like patromor and sodium zirconium, which can be used to control this hyperkalemia rather than simply stopping the mineralocorticoid antagonist. We also know that now the GLP-1 agonists are very useful for control of obesity. So in a patient who's obese, diabetic, and heart failure, the combination of dapagliflozin or empagliflozin along with GLP-1 agonist would be an extremely valuable factor to control both the diabetes, the obesity, and the heart failure for these patients. And then, of course, the potential infrastructure, which is also very important. And I think we need to look at electronic health records to reduce errors, etc. We need patient monitoring devices which can give early warning, but we have to be careful about false alerts, etc. And of course, the cost effectiveness, wearable active monitor smartphones. These are very important. I think as Professor Weber mentioned, the involvement of the patient of treatment of his hypertension improves hypertension control. Similarly, the involvement of the patient in heart failure is very important. So you give them tracking devices, dietary recording, weight management, monitor their weight. So involve the patient through use of smartphones and other technologies to take part in their own heart failure management, and that way they will significantly improve. So I end by highlighting the key points. Is the aim of the 24 guidelines was actually to provide a framework. As I mentioned, no dramatic new trial came in, so no dramatic therapy change, but to provide a framework which is important, the importance of checklists and algorithms, the importance of a multidisciplinary care, multiple complex decision making is required, and of course, solid foundation of knowledge of all these drugs and management is very important, and which is why the importance of a heart failure clinic run in a multidisciplinary fashion by people with solid knowledge. Heart failure is a major public health concern, and GMT and heart failure clinics will produce a significant benefit for these patients. And the questions have emerged about what is the optimal deployment of all these factors. But I think the guidelines give us a nice framework on which to base a heart failure management. Thank you very much indeed.
Thank you, dear sirs. Thank you, Professor Weber and Professor Dalal for the wonderful additions. And we are very sure that the audience, which has been part of the audience, all the attendees have benefited hugely from whatever has been discussed. We now open up for a panel discussion between Professor Weber and Professor Dalal. Over to you, sirs.
Dr. Weber, what were your thoughts about the heart failure? What do you think are the biggest problems that you see with heart failure management today?
Well, you go through the guidelines and it can be a bit intimidating because there are so many drugs, so many recommendations, so many things to look out for. To me, the biggest problem is we tend to treat these patients. We see them develop heart failure. We start appropriate treatments. And maybe we get improvement in symptoms, perhaps an improvement in ejection fraction, and we stop there. We think we've done a good job, but we don't really ask ourselves, is there something that is a correctable cause, or at least something where we can make an intervention and improve the situation altogether? And the thing I find most difficult, because it's expensive and requires referral away, usually I don't have to worry about valve disease because we've had ultrasounds. We know what's going on in the heart as far as the valves are concerned. Usually, they're not always, but I often think about, does this patient have ischemic heart disease? Does this patient have coronary disease that isn't symptomatic, but may be a big factor in going on in this particular instance? And so I was going to ask you, since you're more connected with this, should I, as a routine, check the coronaries, at least maybe by doing a CT angiogram, before I try to send them to a cath lab to have an angiogram? Should I be doing some sort of diagnostic workup to see if I can identify coronary disease that ought to be treated?
My answer to that would be the yes, that we should rule out whether there is coronary artery disease or not, because I think diagnosing the etiology of the heart failure is very important. For example, you could miss transthyretin or sarcoid or something similar. You don't want to with ischemic. But the problem that I find is that once you diagnose ischemic heart disease, say a patient's had an infarct, his ejection fraction is 30%. Unfortunately, as one of the recent trials, I forget the name of the trial, presented in ACC, in fact, I think last year, was that probability testing doesn't help to decide whether the revascularization will benefit or not these patients. So there are trials, which of course the Stitch trial was the earlier one with bypass surgery, and the recent trial with PCI. And they found that viability testing did not help whether PCI would benefit the patient or not. The only thing that came out was that if you had a large scar, then you will not benefit from any interventional procedures. If you had a small scar, then you'd benefit. but viability testing did not help to decide. So though you know that the patient has ischemic heart disease, whether you should revascularization or not revascularization still remains debatable. So that's unfortunately a problem. But in answer to your question, I would definitely want to know whether it's ischemic or not, because if you have normal coronary arteries, then clearly that bit of it gets removed.
Okay, thank you. Thank you.
How often do you prescribe, Dr. Weber, renal denervation now? What would you think is the percentage of patients that you think actually need renal denervation? And what is your thought about fenrinone as a mineralocorticoid receptor antagonist?
I would say the proportion of people who need renal denervation is quite small. I mean, oh, sorry, I'm being harassed by. It's quite a small percentage in my practice, because I think I'm pretty good, and my colleagues are pretty good at treating hypertension with available drugs. But we have the situation where patients are being offered good treatment and not taking it reliably, poor adherence. And the FDA recognized this. And so the indication for renal denervation is poor control of blood pressure or inadequate control of blood pressure, despite prescribing medications and recommending lifestyle changes. In other words, there may be people who are not taking their medications or not taking them adequately. Should we treat them? And you could say, no, we shouldn't. It's their problem. It's their fault. If they took their medicines, we wouldn't need to do this renal denervation. On the other hand, if after months and months of trying to improve their treatment and the pressure is still high, do I want to take the risk that they're going to have a stroke or a heart attack or some other major event while I'm giving all sorts of advice, writing all sorts of prescriptions, not making the sort of progress I need to make? And sometimes the only answer to that problem is denervation. And that has now been accepted as a potential. Where you are ahead of us in India, I suspect, is you'll probably be able to do this procedure at a far more cost-effective level than we have here in the States. Here it's going to cost many thousands of dollars. I suspect in India it'll be much more affordable. I'm still very expensive for people who have very low incomes, but I think more feasible than here.
A couple of questions I see out here for Dr. Weber. One is, I asked about fenrinone. Somebody's asked about pateroma. So we know that fenrinone is good for kidney, and now all the nephrologists are using fenrinone. So should we use that? And what about the use of pateroma commonly with heart failure to reduce potassium?
Well, I happen to like pateroma. I think it is useful, and because what worries me is that if I start backing off my spironolactone or eplerenone, I'm going to not get the benefits I expect from those drugs. So I would suggest very strongly that pateroma can be useful. I mean, we give dietary advice and all that sort of thing. And of course, the other problem we often run into is that renal function is often compromised in these patients. And if someone's got a low EGFR and the potassium is rising because of that, it becomes a very difficult sort of management. And now should we back off a little bit on the ACE inhibitor or the ARB or the sacubitril valsartan therapy? It does get complicated, and the advice to refer people to an advanced center, I think, becomes very relevant at that point. Yeah, because those are the sorts of problems that are really very difficult to manage.
Right. There's a question here which says, in viral myocarditis and guideline medical treatment, how long does it take to improve? Well, myocarditis is a different subject by itself in the sense that if you have an acute heart failure because of myocarditis, patients would normally improve and become normal even if you didn't treat those patients. They, of course, need to be treated in the immediate phase when they are in congestive heart failure. But this is one of the situations where I personally feel that you start the guideline medicated therapy, and when they completely normalize, that probably this is one instance where you could probably reduce or cut down the drugs and even maybe stop them. So when you're in acute episode, you probably maybe one of the situations where you may be able to stop the drugs. But clearly, if you have a cardiomyopathy which is of unknown etiology or ischemic cardiomyopathy or other forms of cardiomyopathy, then clearly you do not stop the drugs and continue the drugs, because we know that if you stop the drugs, the ejection fraction can drop down. And that's not only just a problem, but not only can it drop down, but it may then not improve when you restart the drugs. So please keep that in mind. So it's not that, okay, we'll restart the drugs and the ejection fraction will normalize again. It may not happen. So it's important to keep that in mind as well. Any other, Parthasathi, any other questions? I'm seeing some questions here.
Yes, sir.
Somebody, yeah, please
So
go
we
ahead.
also had Dr. Anubhav who asks, for patients with CAD and heart failure, does a planned PCI actually improve heart failure symptoms or not? Your views on this?
Well, the most recent trial presented at ACC suggested that it did not really make that much difference, so that all patients with ischemic heart disease having a PCI did not necessarily improve their heart failure. So clearly, it is difficult to judge which patients would benefit and which would not. Unfortunately, they also showed that viability testing, and again, viability testing is difficult. Which test would you use for viability? MRI is said to be quite useful. A stress echocardiogram probably matches best, as seen in the earlier trials. PET scan often is useful. So you can use variety of these tests to detect viability. But clearly, in spite of using these tests, a viable myocardium and PCI did not always show benefits. So it's important to remember that. If you have a large scar, like a thinned out large ventricle, even if that artery is blocked and you do a PCI, these patients do not benefit. However, if the patient's myocardium is still thick, there is evidence of viable myocardium seen, then one may think that it will benefit. Those studies have not shown so. But clearly, those who improve their ejection fraction after revascularization have an improved prognosis. So clearly, that is shown as well. I unfortunately forget the name of the trial. It was presented last year in ACC.
Could I ask a question, Dr. Dalal? Because this is an issue that I see all the time and have problems with. We see patients or get patients sent in consultation who already were hypertensive and are already on a good dose of, let's say, an angiotensin receptor blocker, a decent dose of a diuretic, and now they have heart failure, and the guidelines say we should start all four therapeutic directions: the SGLT2s, the mineralocorticoid agents, and so forth. Everything should be started pretty much at the same time, the beta blockers and so forth. And yet we already have two drugs in pretty high dose. Should we reduce the doses of those drugs to allow us to introduce the drugs we now need to add? So I've got an ARB in a high dose. I've got a diuretic in a pretty high dose. Should I cut those doses down so I can now add my beta blocker, my SGLT2 agent, and so forth, so that I have so I don't get into hypotension and those sorts of problems?
Yeah, I would certainly think so, because I think clearly there is evidence that in patients with heart failure, that four drugs, all the four drugs are beneficial because you're acting on different systems. So if you got a high dose ARB and you got a diuretic, you're only looking at diuretics. Of course, you're only looking at symptomatic. The ARB or AC inhibitor, you're blocking one particular system, but I think you need to block the others. So if the patient has got low blood pressure is well controlled, but he's in heart failure, I would certainly change him over from ARB, ARNI into to ARNI from an ARB or an AC inhibitor. I would certainly add beta blockers in SGLT2. So my would be that once you have heart failure, try and get all the four drugs. And if you need to reduce some of the blood pressure medicine, so be it. But I think better to do all four drugs. But the problem usually is that we don't see so many patients with hypertension, heart failure. The hypertension is never a problem when you're treating heart failure. That's so easy to treat. It's the hypotension.
Absolutely right.
Is always the problem.
Yes, that's true. And I'm sure you know the real problem is that when we look at the people with heart failure, I would say fewer than 50% of them have all four treatments in place. Even in the States, I would say you're lucky if you got two out of four.
Dr. Weber, you needed to go, so please tell us if it's time for you to leave, because I see the time which you mentioned has come now.
Listen, I'm afraid I have to thank you for including me in this program, and apologize for having to leave early, but
Professor Weber,
I have an important faculty obligation at the school, and they've been, I think, hit 5 urgent calls. So please forgive me for my early departure. I've learned a lot from you, Dr. Dalal, and I hope that I was able to contribute a little bit of what's up to date on hypertension. And I look forward to working with all of you again as soon as possible. Thank you so much.
Thank you very
thank
much
you
for
so
your
much, Professor Weber. It was a pleasure and honor to have you with us. Thank you.
Thank you.
Thank you so much.
Appreciate it very much.
Parthasarathi, if they want
Sir,
me to take any
just
questions,
the
I'm happy to do it.
last question for the day, sir.
Yeah.
So we have a question from Dr. Srinidhi, who asks, so about GDMT escalation at the hospital, and kindly give your clinical pearls. You already have done a wonderful job of that, sir. So just a follow-on question to the same, considering hyperkalemia risk, which was getting discussed. So would you want to start ARNI and MRA maybe at different times, or would you start at the same time to the patient?
See, when
Can
the
you start?
patient comes with heart failure to the hospitalization and the patient is in ICU and requires intravenous therapy with diuretics or is on inotropes, that is not a good time to start anything. So clearly, that is not the time to start beta blockers or the time to start ARNI or SGLT2. So when the patient's in ICU, patients may be on inotropes. So first they have to get off the inotropes. Then when they are reduced intravenous diuretics or onto oral diuretics, that would be the time when they would be shifted from the ICU to the room. That's the time to introduce the drugs. If the patient is tachycardic and the blood pressure is not too low, then clearly beta blockers are important and should be started. Also, at that point, it's a good time to start ARNI because often they're still wet. So wet heart failure responds better to ARNI. So you start ARNI. If the patient's creatinine is high or borderline high or the potassium is a little bit high, I would not start ARNI and AC and mineralocorticoids at the same time. I usually don't like starting both because I would like to start ARNI first, see the response to the creatinine and the potassium, and then add the mineralocorticoids. I would start mineralocorticoids in a small dose. Even eplerenone is my choice because aldactone, especially spironolactone in males, produces gynecomastia. So rather than waiting for that to happen and then shifting, I usually start eplerenone. Now, eplerenone potency is about half that of spironolactone. So if you start with a small dose like 25 milligrams of eplerenone, it actually equals about 12.5 of spironolactone, which is very well tolerated. And if the potassium doesn't go up, I'll increase the eplerenone from 25 to 50 milligrams. ARNI, I would start with a small dose. If the BP is low, I would start with as small dose as 50 milligrams, half twice a day. So I have no hesitation in starting half twice a day. I would then increase it to 50 milligrams twice a day at least. And once that is done, the patient's usually fairly stable and you can start SGLT2 inhibitors. In fact, SGLT2 inhibitors are the easiest to start because they don't really produce much problems with the kidney, nor with the potassium, nor with the blood pressure. And in fact, if the patient's hyperkalemic, they're easy to control the hypokalemia. So adding SGLT2 inhibitors will actually reduce the incidence of hyperkalemia. So SGLT2 are the most easy to use. Beta blockers, of course, we are using. ARNI, we are using. And mineralocorticoids. So what I would do before the patient goes home is that they should be on all these drugs before they go home. The reason is that you can make out while they're in hospital whether they're tolerating these drugs or not. Secondly, when the patient is already on these drugs in the hospital and then you prescribe it on your discharge paper, the patient is more likely to take the drug. Secondly, when the patient comes to you in the OPD, and you should call them within 1 week in the OPD, not 1 month. 1 week later, they should be in the OPD. You reevaluate this potassium, creatinine, blood pressure, and heart rate, and then adjust the dose. If the patient say already on half milligram, half tablet of say ARNI twice a month, twice a day, then it's very easy for you to increase it to 1 twice a day. Well, starting a new drug in the OPD, doctors are always worried. Patient will go home, we don't know what will happen, will the blood pressure fall, etc. So starting all the 4 drugs, even in small doses, I think is very crucial before the patient is discharged. If you do that, then at least the patient will be on all four drugs, and then it's much easier to titrate the drugs in the OPD rather than introducing a new drug. So that's my way of thinking of the patient, treating these patients. And then, of course, you can add your ivabradine if the heart rate is high. If the pulse rate is high and the blood pressure is not low, then I would rather increase the dose of beta blockers. If the heart rate is high and the blood pressure is low, I would put on ivabradine. Vericiguat, again, when to start? Some people say wait, optimize all the 4 doses of drugs. If the patient comes back at heart failure or doesn't improve, add vericiguat at that stage. Some people are pushing vericiguat early, but there's no data to show early vericiguat benefit. Trials with vericiguat have been done on worsening heart failure, but clearly it's an interesting drug. Number one, is much easier to use than ARNI. It doesn't produce problems on the kidney. It doesn't produce problems on the potassium. It doesn't have any changes of heart rate and blood pressure. So it's a much easier drug for a cardiologist or physician to use than ARNI, for example, or SGLT2. It doesn't produce urinary infections and mycotic infections, etc. So it's an easier drug to use. How effective it is? Yes, it is effective, but we don't know whether it's more effective than ARNI or not. Probably not. We don't know what effect vericiguat has on ejection fractions. We don't know whether it improves ejection fraction or not. So clearly, vericiguat has a lot of further investigations that need to be done. It's a good drug because it's a safe drug. So whenever you have a safe drug and it has little bit benefit, also it's easier to use, and therefore I also use it quite often. So that's my thoughts on starting GMT in the hospital.
Wonderful, sir. Wonderful. Covered an entire session and with a lot of clinical pearls with the same. So we are at the end of our audience questions right now, and we have the honor of hosting you for the day. Dear audience, it was an honor to have each and every one of you too, and we thank you for actually taking your time on a busy Friday evening. We are very sure that the clinical pearls discussed in the webinar would ultimately empower you in your clinical practice and ultimately, of course, to improve patient and patient care outcomes. We also thank our technology partners, DocMode, for actually aiding with the very smooth streaming of this webinar. And once again, I close with a vote of thanks, once again, finally, to Professor Dalal for his wonderful oration, and also to Professor Weber for his discussion on hypertension. Thank you, sir.
Parshasati, I would like to stop by end by saying that for the audience, please do not forget vaccinations, because that's something we always forget. So vaccination for influenza and pneumonia is extremely useful. A patient with heart failure who gets pneumonia is a common cause of death in patients with heart failure. So vaccination for pneumonia and influenza is extremely important. And a recent study has also shown that, in fact, cardiac rehabilitation is excellent, not just for heart failure, but even patients with angina. There's a big study showing that, in fact, rehabilitation works wonders. So don't forget cardiac rehabilitation. So these may be something which you don't think of, vaccinations and rehabilitations, but they form a very important part of treatment. And also always look at iron deficiency and give intravenous iron. So those are things which are not in the 4 main pillars, but they are extremely important, what I would call other pillars of management of heart failure.
Thank you, sir.
Sure. Okay. Bye-bye.
So I think the final words of this good. Thank you so much.
Sure. Bye.